Is it ever an option for surgery for these limited stage patients?
I'm so glad you asked that because I think surgery is something we're too dismissive of in small cell lung cancer. Right now, surgery is for a very selected population of patients with small cell lung cancer, generally confined to patients that have a single solitary lesion in their lung, usually a couple of centimeters at most in size, no lymph node involvement. Those patients might have surgery initially, or they might have what's called stereotactic radiation initially, and then that's followed with chemotherapy. I think as our therapies get better for small cell lung cancer, as we're able to control the disease we can't see, in addition to the disease we can see, I hope that we'll start to introduce more surgical options for patients. Patients like the notion of surgery. Patients like having the cancer out of them. And we are, I think, too restrictive in applying surgery to small cell lung cancer in a way that maybe limits our opportunities for cure for those patients with some early stage disease.
And what, in your opinion, is the reasoning for some of those restrictions or the thought
I think
processes around it?
historically it was simply the futility of the approach that the cancer was going to come back anyway, and that surgery just delayed the time before the patient might get to chemotherapy. There are other variables. Small cell lung cancer patients are often, but not always, smokers, and so that can impair their candidacy for surgery. Right, you have to have healthy enough lungs to tolerate removal of a lobe or more of your lung. And they may have other comorbid illnesses that make surgery less viable. But I think realistically, it was just if the cancer is going to come back anyway, why put patients through the surgery? But if things like immunotherapy can, as I said before, control some of that disease we can't see, right? We always say surgeons can only cut out what they can see, right? They can't tell if there's cancer cells in the bloodstream, and if there are, they can't do anything about those with a scalpel. So if we have a better way to control that, then controlling that primary tumor and the local lymph nodes surgically then becomes a more attractive option. And we've seen that in non-small cell lung cancer, right? As treatment has evolved there, we're offering surgery to more and more advanced patients now.
Yeah, and I was going to say, it would be interesting to see, and I hope to see it, studies done in these surgical candidates in the neoadjuvant and adjuvant setting, or the before surgery or the after surgery setting, because there are similar challenges in early stage non-small cell, to your point. They can only cut out what they can see.
Yeah, and I think neoadjuvant in particular, so neoadjuvant means treatment before surgery. And I think that in particular is attractive for small cell lung cancer because we have therapies that work exquisitely well at shrinking the tumor, controlling the disease. It just doesn't control it for long enough. But if you can shrink the tumor up, obliterate a lot of the disease, both the visible and invisible, microscopic disease, then you might take a patient that's not a surgical candidate up front and convert them into a surgical candidate within a 2 or 3 month span of neoadjuvant therapy. And so I'm aware of neoadjuvant ideas that are being kicked around. And so I think that's a way the field is going. And I'm really enthusiastic about seeing some attempts at this and bringing surgical opportunities to more patients.
I love that. Something to keep our eyes on in the future.
So I'll be brave if you're brave. I'll be brave, but only